All right, let's jump right in. Today, we're putting on our detective hats. We're going to look deep inside a beating heart to solve some of its most complex puzzles, and our main tool is the incredible power of cardiac MRI. And we are starting with a real head-scratcher. Just imagine this. A patient shows up with all the classic signs of a heart attack. You know, the chest pain, the whole deal. But when you look at their coronary arteries, they are perfectly clear. So what in the world is going on? We're going to find out. Stick with me. Now, to solve mysteries like that, every detective needs a key. And in cardiac MRI, our master key is a technique called late gadolinium enhancement, or LGE for short. Honestly, if you can wrap your head around this one concept, everything else just clicks into place.
So here's how it works, and it's actually beautiful in its simplicity. First, we inject a special contrast agent. Now, this stuff washes out of healthy, normal heart muscle really fast, in just a few minutes. But, and this is the magic part, any abnormal tissue, like a scar or inflammation, it just soaks that contrast up like a sponge and holds onto it. So when we scan the heart a bit later, those problem areas light up like a Christmas tree, showing us exactly where to look.
Okay, this right here, this is the fundamental fork in the road. The pattern of that bright signal tells us almost everything we need to know. If the bright spot starts on the inside lining of the heart, the subendocardium, and it follows the path of a major artery, we call that ischemic. That means a classic blockage, a heart attack. But if the pattern is somewhere in the middle of the wall or on the outside, well, then it's non-ischemic. That one distinction is the first question we ask, and it changes everything.
So let's put this into practice and look at our first category of cases. We're talking about cardiomyopathies, which are basically diseases of the heart muscle itself.
First up, dilated cardiomyopathy. The easiest way to think about this is a heart that's gotten big, baggy, and weak. It's just not pumping efficiently. And look at this. Our LGE pattern immediately helps us figure out why. If we see that classic subendocardial pattern, we know it's probably from old damage from a blockage. But if we see that bright signal right in the middle of the wall, we start thinking about other causes, things not related to the arteries at all.
Now, let's contrast that pumping problem with a filling problem. With restrictive cardiomyopathy, the heart muscle itself has become too stiff. It might pump okay, but it can't relax properly to fill up with blood. Imagine trying to fill a balloon that's made of hard plastic instead of rubber. That stiffness is usually because something has invaded or infiltrated the heart muscle. And that idea of infiltration brings us right to our next group of diseases, what happens when something that doesn't belong there gets into the heart muscle.
A classic example here is cardiac amyloidosis. This is where abnormal proteins basically start building up all over the heart, making it incredibly thick and stiff. The LGE pattern is just unmistakable. It's this diffuse, bright ring that goes all the way around the inner surface of the ventricle. And importantly, we're not just looking at pictures. The patient's history gives us huge clues, like a history of multiple myeloma.
Okay, get ready for another clue, and this one's a little weird. It's just a number, 350 milliseconds. What on earth could a measurement of time possibly have to do with diagnosing a heart condition?
It's like a secret handshake for spotting amyloidosis. This number refers to a technical MRI setting called the inversion time, or TI. Think of it like a camera's shutter speed. Because that amyloid-filled muscle soaks up the contrast so differently, we have to use a much longer shutter speed to get the picture just right. And when we do that, sometimes the heart muscle itself becomes even brighter than the blood inside it, which is a massive telltale sign that we're dealing with amyloid.
Another type of invader is inflammation, or myocarditis. The key thing to remember here is that this is always going to show a non-ischemic pattern. Always. This isn't a plumbing problem in an artery, it's inflammation in the muscle. And that inflammation tends to show up on the outer wall or in the middle, often on the side wall of the heart.
So we've spent a lot of time talking about the muscle, but what happens when the muscle is perfectly fine, but the problem is actually the sac that it sits inside?
This is constrictive pericarditis. The pericardium, that sac, thickens up and gets hard, and it literally starts to squeeze the heart, preventing it from filling up properly. MRI is amazing here because we can actually measure how thick that sac has gotten. And notice the LGE finding. The heart muscle itself is normal because the problem is entirely on the outside.
And now for the buzzword that every radiologist just loves to see, the diastolic septal bounce. When the heart is being squeezed like this, the wall that separates the two ventricles, the septum, it kind of bounces or wiggles back and forth. Seeing that motion on the video clips of the MRI is the classic slam dunk sign of constriction.
Okay, so this sets up one of the great diagnostic challenges in cardiology. Constriction, that squeezing sac, and restriction, that stiff muscle, can look and feel very similar to a patient. But they are completely different problems with completely different treatments, and MRI is the perfect tool to tell them apart.
And this table just lays it out so clearly. MRI gives us a checklist. Is the problem in the sac or the muscle? In constriction, the pericardium is thick. In restriction, it's normal. Is that septal bounce there? Yup, in constriction. Nope, not in restriction. Is there any abnormal enhancement in the muscle itself? No in constriction, but you bet there is in restriction. Just clear, distinct answers to tell them apart.
All right, let's circle all the way back to where we started. That patient with chest pain but squeaky clean arteries. It is time to unmask this great impersonator of heart attacks.
The diagnosis is Takotsubo cardiomyopathy, but it's much better known by its nickname, broken heart syndrome. And yes, it is a real thing. It's a condition we often see in postmenopausal women right after some kind of major emotional or physical stress.
And it gets that wild name from this amazing analogy. A takotsubo is a type of pot that Japanese fishermen use to trap octopuses. During one of these broken heart episodes, the bottom of the left ventricle balloons way out, but the top stays narrow, making the heart look exactly like one of these traps. It's pretty incredible.
So, how do we prove it's Takotsubo? We see that classic apical ballooning shape. We've already confirmed there are no blocked arteries. And here it is, the absolute key, the crucial finding that solves our initial mystery. There is no late gadolinium enhancement. The muscle is stunned, not scarred. The complete absence of that bright signal is what proves this is not a heart attack.
And that really is the main takeaway here, isn't it? Whether it's the subendocardial line of a heart attack, that bright ring of amyloid, or even the complete lack of a signal in Takotsubo, decoding what's wrong with the heart on an MRI is all about recognizing the pattern.
Learning these patterns is everything, but it does lead to one last, much tougher question. Now that you can spot the usual suspects, what about the diseases that don't play by the rules? The conditions that can mimic almost anything else? Which disease is the true master of disguise, the most dangerous imposter of all? Well, that's a puzzle for another day.